Before we jumped into other stuff, let's get back to some of the basics. What do you do when you see patients? And I've been asking a lot of my colleagues the same question, melanoma experts, and I want to give our viewer a kind of flavor to sort of see how different folks go about what's the interaction with the patient. So let's say a patient first coming to you with high-risk patient, right? Personal family history melanoma, lots of atypical moles, and they come into your clinic and for an inpatient visit. What's your process? What do you say to them? How do you examine? Let's go through that.
Right, that's a great question. So luckily we have what we call as at the University of Michigan, we have something called as Melanoma Clinic. So any patients who are diagnosed with a melanoma, they go through that melanoma clinic before they come to what we call a SCAD clinic, which is skin cancer clinic, where we see high-risk melanoma patients, high-risk non-melanoma skin cancer patients. So that's where my interactions with the patients happen, which is in the high-risk skin cancer clinic setting. So the first thing is review their charts, review the history, make sure that what has gone so far, what stage of melanoma are we dealing with, and everything the first. So I would do a good review of whatever has been done so far, whatever the patient knows before I get into the clinic. And the beauty of working in University Hospital is all these patients are first seen by our residents, and then the residents come back to us and present those cases to me, and then we take it from there. So that's the privilege. But at the same point of time, you have to, because you are signing on the dotted line, you also need to review their charts before you go in. So based on that, once I have, let's say, for example, if the patient has, as you said, personal history of melanoma, family history of melanoma, and multiple atypical nevi. The first thing is after, going inside the room, I would ask if there are any lesions of concern. I always start with that just because most of the melanomas are either identified by the patient or by the close family, and we come next. So that's the first thing. As soon as we get that thing away, then we start with a complete total skin exam, full body skin exam, which starts from the scalp, looking at every place, the eyelids, inside the mouth, in the ears, nail beds, nails, a complete skin exam, thorough skin exam, including internail cleft, between the toes. And then after I do the first review, then I kind of stand back and take a look at all the moles. If they have multiple moles, I kind of take a look at the moles, especially on the back. And I love dermoscopy, so I follow all of these concerning lesions with whatever clinically concerning lesions which I have with the review with the dermoscopy, and make sure they are dermoscopically non-concerning. So a clinical concern followed by dermoscopy evaluation of all of these lesions. And once I've done with it's not a complete exam without doing a dermoscopy evaluation in my knowledge. So I do that in all my patients. I even sometimes look at pigmented subcaries if it's concerning. So that's how important for me dermoscopy is. So once I've done that, then I go and check their lymph nodes. Followed by lymph nodes, I make sure that there's no organ involvement like organomegaly in the form of palpating liver and spleen. And then finally, kind of review of systems, make sure everything's okay. And once this is all done, of course, we biopsy suspicious lesions and things like that. But then, this is a comprehensive kind of review of all body parts, including lymph nodes and organs. That's how I do in my clinic.
Yeah, it's kind of interesting. Like, you and I, we all have the same approach, right? And a lot of folks that I chose to interview, and I sort of feel like, we have the same approach. I mean, and that's why you guys are the melanoma experts, and that you have this approach of sort of you want to detect the melanoma at the earliest stage, but at the same time, you don't want to perform a lot of unnecessary biopsy, right? And so that combination of whole body exam plus dermoscopy plus photos and it's a series of sequential action that sort of allow you to pick up melanoma early. I find this really interesting, and you're the first one that actually said this, which is true, but that most melanomas are first noticed by the patients or the family members and the friends, and they're the one who sort of bring that the attention to their clinician and get this screened, right? So I mean, I think this is a very powerful message that, that's one of the reasons I always tell some of my high risk patients to get self-exam basically. And
Right. So just to kind of this spiel, which I kind of tell patients is like once I see that they are there, I tell them to look for, if they're over the age of 40, I ask them to look for any new moles which happen, because you should not develop a mole theoretically after age 40, and none of your moles should grow after age 40. And if any of those two changes happen, give us a call. So this is another thing which I kind of follow up in my clinical practice all the time. And it's actually helpful.
yeah, I mean, I think it's really interesting you put an age qualifier right there, right? Because we know there are a lot of, like in adolescence period of time, that you see the mole actually change and getting bigger, get new lesions. It's once you reach a certain age that you don't really want to see those new nevi popping up, basically. So just how long does that process take? Let's say for a typical, your high risk patient, let's say someone who have like 40, 50 nevi, one history of melanoma, and by the time they walk into your door and by the time they leave, how long does that take?
So they go through two
Yeah, you get the two layers
two
because you have
pairs
a
of eyes,
resident.
right?
Yeah.
So my resident takes a look at it, makes sure that everything's okay. So we kind of go in and say, this is a twofer, like you get two people for one price kind of a situation. So, but looking at it, what I mean to say is, so that it's going to be a thorough exam. So it's somewhere anywhere between 20 minutes to 30 minutes or to 40 minutes based on the number of nevi and the complexity of the patient. Well, let's say, for example, somebody who has MIS and very few moles, maybe it ends within first 20 minutes, whereas somebody who has like 100 moles and they are atypical nevi, then yes, it takes around 30 to 40 minutes.
Yeah, especially consider that you have two people looking at the same individual like separately, right? So two sets of eyes looking at it. Yeah. And I agree with you. Some of those patients with lots and lots of atypical nevis, it can be challenging, especially when you have to bring up the total body photography for comparison, right? So let me ask you another question. In your mind, what's the difference between your resident and you, besides you have more gray hair? And but I ask this question is because how does a patient? So what are you looking for that allow you to pick up earlier melanoma compared to maybe perhaps some of the inexperienced person like your resident? What are they missing?
So the first thing first, like we are looking at a global picture, and the experience adds to it. Like when you're looking at the lesion, like one of the things is like because I teach and train dermoscopy, that's where I kind of pick up early melanomas, and there are situations where the residents are not able to make the difference, whether it's a melanoma specific structure or things like that. That's where I come in and I help them out, because most of my residents are really good at picking up things. And sometimes we also have this kind of the resident goes and marks some of the lesions, which he wants me to take a look at, like, make sure that he or she is not missing any of the lesions. So we kind of take a closer look. I use dermoscopy skills to kind of differentiate whether it needs to be biopsied or not. or not. So things like that. That's where I think experience, the training comes in handy when you're looking at somebody who has like hundreds of nevi.
Yeah, and I think one of the things I sort of rely on is like this ugly duckling concept, right? You basically sort of, like you said, you sort of step back looking at this entire sector and looking for things that sort of jumps at you that looks different. And then like you, I use a dermoscopy, like sort of looking at most every single lesions. And I actually I have this new device now. It's this ChemField 360 device. Instead of using dermoscope, it's this camera, high resolution camera. And I put on the live mode, and they can basically just scan across every single lesion. I'm looking at this on the 30-inch TV monitor. So it's like, it's a great experience. And then at the same time, I do some teaching, educate the patient. So